Fluid and electrolyte intravenous therapy for Introduction to Nursing Concepts. This is Martha Olson, Part 3. We left off looking at fluid volume deficit. We move on now to overhydration or fluid volume excess. The signs and symptoms we would see in a patient include high blood pressure because there's more volume to have to push around through the vessels. Those pulses are going to feel bounding. When you go to feel a radial pulse, you know it's there because it's really forceful. We check jugular vein distension and we notice those neck veins are sticking out. We can observe them just by having the patient turn their head away from you, having them at that 40-degree angle. They have edema, they've gained weight. Their hematocrit is going to be lower because it's hemodiluted. It's in a larger volume, and so the hematocrit looks abnormally low, but it's not. When we correct the fluid volume overload, the hematocrit should come back to within normal. The intake is greater than output, and we notice that the specific gravity lab value is going to be decreased, again because of hemodilution. Causes of overhydration can be from organ failure such as the heart, the kidneys, or the liver, or too many IV fluids or even PO fluids can cause overhydration. Our treatment then is to look at the cause. Do we need to give them a diuretic to help get some of that fluid off so that we can improve the oxygenation and the patient comfort? Do they need oxygen? That would be your priority in this one because of the airway. Do they need a little morphine, IV morphine, to help them relax? As a nurse, we can do interventions without a physician's order that include listening to the lung sounds, auscultating lung sounds both anterior and posterior to see is there fluid in the bases. Put the patient on intake and output. Complete a daily weight on the same scale, the same time every day. We can't do a fluid restriction diet or order it, but we can kind of back off the amount of fluids that we offer to the patient until we can talk with the physician to see about getting a diet that maybe is so many milliliters per day that they can have. Our assessment then is looking at their urine output, their skin turgor. Does it tent or does it not? With fluid volume excess, the skin turgor should be nice and springy and healthy. Look at your IV. Do they have an IV that's running at a very fast rate that we need to talk with the physician to get an order change? And then your perfusion is a big one. Is the strength of the pulse, the blood pressure? Do they have quick nail blanching when we assess that? And your urine output with fluid volume excess is typically colorless and in larger volumes or amounts. When we look at a kilogram of weight loss or gain, it's equal to 1 liter of fluid. So 2.2 pounds is a kilogram. So if I lose 1 kilogram, I've lost a liter of fluid. If I gain 1 kilogram, I've gained a liter of fluid. So the kilo and liter make it easy to calculate that way. When we look at daily weights, there are many different ways. Most of the hospitals today are using the bed scale. With that, you have to make sure that the head is down in the supine position, that only the blankets and pillows and chucks and everything else that was on the bed when you zeroed the bed is on there. Otherwise, those add a lot of weight and artificially elevate the weight that you obtain on the patient. In the long-term care, I'm hearing most of the students that tell me they work there, the weights are obtained once a week with the bath. They have kind of a sling scale that they get the resident up in this sling. They get a weight. They get them in the whirlpool and do their bath at that time. If you work in a clinic, you'll use more of the standing scales. With those, make sure they take their shoes off, that they're standing tall, that they're able to stand on the scale for that. Getting an accurate weight is very important because doctors will base many things off of an accurate weight. If they see the patient's weight is up 4 pounds, they might increase the diuretic. They might put a fluid restriction on them. They might add a second type of diuretic. So getting an accurate weight is very critical for the patient to make sure that we are doing the right thing. On the chair scale, I know that if the patient is not sitting all the way back, and their feet are not on the pedestal on the bottom, it can give an inaccurate weight. Make sure you're doing it at the same time of day. We typically get it at the end of the night shift, early morning, just after the patient voids. So if at 5 a.m. they wake up and they say, "Can you take me to the bathroom?" Let them void and then get the weight for the day. The bed has to be zeroed or cleared out before a patient is in it. So that's one of the first things we do before we admit a patient into a room. And then there are times we recalibrate or re-zero it if we're getting weights that we do not think are accurate. When we look at the fluid and electrolyte balance, some of the consequences can impair perfusion and oxygenation. That's our number one priority. Impairs cerebral function, impairs neuromuscular function. This information is coming from the Concepts book by Giddens. When we look at the impaired cerebral function, we know that it's because of the swelling and edema. The hypernatremia or high sodium level causes that and can even cause decreased perfusion and seizure activity for that client. Impaired perfusion and oxygenation, we see this often in clinical practice with pulmonary edema. Remember that fluid in the alveoli keeps the oxygenation and perfusion from being able to happen. It's like the oxygen has to swim across the river of fluid to get to the alveoli to be able to exert their oxygen and have their effect. We also see this as a complication of wound healing. When you have a lot of edema and swelling in the tissue surrounding, the oxygen can't get to the side of the wound that needs good oxygenation to heal. So with that edema, fluid pushes the cells further apart, and when we have a lot of interstitial edema with those capillaries farther apart, we can't get good diffusion that heals tissues and helps the patient to have good oxygenation levels. And the last one then is that impaired neuromuscular. We see muscle cramping and twitching, and it's because the calcium, the speed of the ion fluxes can be impacted by that interstitial fluid and the sodium in that interstitial space. We know magnesium suppresses that acetylcholine at the junction. Potassium is that intracellular ion that helps regulate the sodium and potassium pump. So all of these electrolytes can impact the ability of the person to have correct and strong neuromuscular function, and without that we can see potential complications. When we have changes in the fluid balance, the hypovolemia, fluid volume deficit, it changes the vital signs. This is a good one to put a star by. When your volume is low, the heart goes faster trying to compensate for that. It's like when you're late for school and you drive faster because you're trying to get there. The blood pressure is low because when you're hypovolemic, you don't have as much pressure against those vessels. And that's one reason when people have high blood pressure, the first thing they do is tell them to decrease the sodium in their diet, and they may be put on a mild diuretic to help decrease the volume that they have to lower the blood pressure. With fluid volume excess, we see the heart rate also elevated, so both of those have elevated heart rate or tachycardia, and that fluid excess causes that heart to have to work harder, and it's pushing harder, trying to get that fluid down the vessel or down the river because it knows more is coming. From that, the blood pressure is up because you have a lot of volume pushing against the walls of those vessels, and the person is typically breathing heavier and faster, trying to get oxygen from, into those alveoli to be able to be circulated. When we think about GI losses that can contribute to a fluid volume deficit, vomiting and diarrhea are our most common, and we talk about them quite often, but also when we have tubes into the nasogastric, NG tubes, we pull out fluids and electrolytes and acids from the stomach and can contribute to a deficit as well. A patient that's very sweaty or diaphoretic loses a lot of fluid, as well as the person taking a water pill or diuretic like Lasix or Bumex. When we assess the neck veins, that's looking for jugular vein distension or JVD. The procedure is to put the head of the bed at about a 45-degree angle, having the patient lay supine. We look at that angle of Louis in the neck. We have them kind of turn their chin away from you so you can see that. That tells you that there's a lot of volume trying to get into that right atrium of the heart, and they're distended. It's like traffic rush hour in Minneapolis when everybody's trying to get to work and it's slowed down because of the volume. The jugular veins can only take so much of that fluid and get it into the right atrium. So we see a backup of the fluid that shows up in the body as jugular vein distension. There's a lot of nursing diagnosis that will go with this unit. As we look at these, we think of deficient fluid volume related to body temperature, loss of fluids, causing confusion and seizures, and the risk with seizures also goes with the loss of many of your electrolytes that control neuromuscular function. When we look at this, my priority would be ineffective tissue perfusion, the very last one listed, because that's oxygenation, and that becomes the number one on the list. As we look at things we as a nurse can do with fluid and electrolyte imbalance, we can put a patient on intake and output. We can maintain the IV that the physician or the healthcare provider has ordered. We can watch and manage diarrhea as far as keeping track of the number, the amount, checking vitals, and if there is an anti-diarrheal medication or an antiemetic for vomiting ordered, appropriately give those, but also keeping the physician updated on change in vitals, change in amount of output as far as diarrhea. Vasopressin is the med given for antidiuretic hormone deficiency, and then your diuretics again for excess fluid volume. When we measure intake and output, we want to be very careful that we are doing it appropriately, that we measure accurately, so that when we write and chart and document those numbers, that the physician looks at them and knows truly the picture of what the patient drank, how much they voided out. We can't measure insensible losses such as sweat and through the bowel movement, but it does give us a picture of the patient that drank a lot of water, or perhaps they're not drinking very much, and the physician then says, you know what, their intake yesterday was very poor. Let's get that IV started and rehydrate them with IV fluids. If a food is able to melt at room temperature, we have to count it as a fluid, and that would include things like popsicles, jello, and ice cream. Our lifespan considerations then are our vulnerable older and younger populations. We know that dehydration is a problem for our young pediatric and infants, because a large percentage of their body water or their body weight is water. And then our older adults typically have very poor veins. They have loss of muscle tissue, and it sets them up to be higher risk for having problems for fluid volume deficit and overload. IVs on both of these populations can be more difficult to start, especially when they're dehydrated. So sometimes we will look at intraosseous types of IV maintenance to get them hydrated and out of trouble. With IV therapy in class and in the lab, we will be talking about the role of the registered nurse to start the IV. Choosing the site, choosing the correct needle size, choosing which one is going to be best, and then how we maintain that IV and how often we check it to make sure it's not infiltrated or infected. The appropriate time and way to discontinue or take that out, looking at that albocath to make sure that it did not break off when it was in there. And then the appropriate things and how we document is very specific to the hospital and the type of charting that they have. Each hospital I work at or go to clinical with students, the documentation piece for IV therapy is very different, so it's something you'll have to learn when you get to clinical. The biggest thing to know is why we have the IV in, and what are potential complications that as the nurse we are observing for with that. As we think about why IVs are used, many times they're for emergency medications. If that patient crashes and we bring the crash cart to the room, we have a way to get those medications into their system, and IV therapy, IV medications work the fastest, so that's why that route is used. We can use IVs to replace fluids and also provide TPN, total parenteral nutrition, for people that are unable to take in enough calories. We know that the skin is the largest organ. The main function is to protect the body, and so when we start an IV, we put the patient at risk for an infection because we have now introduced a opening into or past that barrier called the skin. And so we want to replace IV sites every 3 days or per protocol, and we want to check them often to make sure that we have them covered with a sterile op site, that we have cleaned the skin correctly before starting that IV, and we want to make sure that we are keeping that area clean and free of infection. We will start on the next PowerPoint with looking at the anatomy to get those IVs started.